If mammograms were the full story of breast health, why do so many women still feel they're missing something? What if the real early warnings, the biomarkers of breast cancer, are hiding in plain sight in your body's own heat patterns? Today, you're going to discover how thermography could help you detect breast cancer years before traditional medicine catches them, and how this technology might shift you from fear into full empowerment. And to break it all down, I'm joined by Dr. Robert Kane, one of the world's leading experts in medical thermal imaging. He's been practicing thermography since 1991 and has 3 international certifications, and has seen firsthand how this technology is transforming women's health.
They found that 40% of the women with these false positives developed breast cancer within 12 years, and most of them within 5 years.
Yeah, 40%, which means what most doctors called false alarms might actually be your body trying to tell you something.
It raises the question, well, if we know that the patient is higher risk, couldn't that change how they're screened, how they're managed to make sure detection occurs earlier?
In this episode, you'll discover what thermography really reveals about your breast health, how it compares to mammograms, MRIs, and ultrasounds, and what simple, holistic steps can actually improve your thermal images over time. So if you're ready to take your health data and your power back into your own hands, let's dive in. Dr. Robert Kane, thank you so much for joining me on Gutsy Chick Podcast to talk about thermography and boob health.
Well, thank you. I'm very happy to be here.
Give us just a snippet of your background so that we know why you're the person I'm talking to today.
I've been involved in the field of medical thermal imaging, otherwise known as thermography, since 1991. I went through basic training. I was, originally certified as a clinical thermologist, someone who knows how to interpret these things, in 1996, and then elevated to diplomate status in 2 associations as of 2001. So I'm actually working on my 3rd certification right now through a Brazilian organization. And between that and 30 years experience, I've seen a lot of things going on.
So it's not just breast health that you're looking at when it comes to these thermal images. It can go all the way to the whole body. Is that right?
Yeah, correct. I mean, when we're looking at thermal images, we're simply looking at heat distributed over the body. And what that will show us are areas that are more active, less active, inflamed, compromised. And by analyzing those patterns and understanding the physiology of what causes those patterns, we can provide information to basically direct doctors where to look further, direct the general public that's getting these tests, what they might be able to do to protect their health.
So what's the difference between thermal imaging and thermography?
Same thing.
Okay. And
Same thing.
you said that you started this back in the 90s. So has that technology been around since then, or was it before that?
Oh, this technology has been around since the 1940s.
Holy crap.
Now, it was much more crude back then, but basically this is military technology. You were looking at what was used in World War II in order to spot ships coming over the horizon. And they would see the heat signatures on these quote unquote infrared images, because that's the spectrum that we're measuring. But they would see those heat signatures and they would know there's something over the horizon, and they can get prepared before the ship was ready to fire.
Awesome.
Yeah. And then in 1956, we had a Canadian medical doctor that was interested in breast imaging, who got the idea of, let's see if we can use this to see how active the breasts are, cancer being more active than normal tissue. And he started mapping out heat patterns, and that's how modern thermography was born in the breast imagery, in the breast industry.
But in the 1950s, breast cancer was not nearly as predominant as it is now. Is that right?
No, not to the extent that we're seeing it at this point.
So when did we see the biggest growth of information data in thermography for breast health, specifically for breast health?
Yeah, we've got 2 phases. Between the 1960s and the 1980s, We had several Mavericks that were doing these in hospitals, teaching institutions, and we were compiling large-scale studies. So a lot of the studies that started off as investigational in the 60s, by the 80s, we now had, 15, 20-year-old retrospective studies where we can look at populations that had cancer and find out what were the thermal signals that seemed to match. We're now going through another renaissance in thermal imaging research because there is artificial intelligence and the idea of training a computer to learn how to identify these things and get there faster or possibly more accurately. So that's the next phase of research that's happening at this point. We may be seeing the introduction of AI stuff, within the next 5 to 10 years. It's getting very exciting again.
Oh, that breaks my heart that it's going to be 5 to 10 years before we can really usurp all the data. I mean, that's the beauty of AI is they've got access to all the information, whereas someone like you've got data to work from, but it's probably a much smaller sample size than what AI can pull from. Is that right?
Yeah, well, the AI has got the ability to analyze much more thoroughly than we can. The AI also has the ability to make this much more accessible because if we have AI analysis, what it does is it removes one step in the process. So right now, an image has to come to me. I have to read it, and then that gets back to the doctor or the patient, and the next steps are done. With AI, you capture the images, and the analysis is done on the spot. So, the time frame, the reason why I say 5 to 10 years is because initially the phase will be AI assisting people like me. And that's already happening, meaning it gives me its impression, it shows me its parameters, and I decide if I agree with it or not. That's actually a safe thing. It's a good thing because we want to make sure that the AI is thinking right.
Yes,
It's
exactly.
only as good as its programming. So it
Exactly.
can be very consistent at getting it wrong if it doesn't understand all the parameters. But I think it's just a matter of time till those kinks get worked out. And then we'll be looking at a situation where we get reliable data just from the AI analysis.
I love this.
Yeah.
So let's backtrack a little bit
Sure.
because I'm going to guess thermography is still not wide known. It's still not something that most women know they can use. Where's the hiccup? Since this technology has been around since the 40s, we've been using it in breast health since the 50s.
Mm-hmm.
Why isn't thermography one of the top things that women go, I need to go do that instead of mammography?
Yeah, no, I mean, I think it's a great question. And the first thing that we have to understand is that for widespread acceptance, we need to have traditional medical acceptance, right? Because they are the torchbearers of healthcare, at least in the United States.
Mm-hmm.
So with thermography started off, it was very exciting. It looked like it was going to replace mammography as a screening technology. Unfortunately, it didn't quite pan out as a replacement. And rather than look at its applications as an adjunct and how more cancers could be detected using both, the profession made decisions, or the medical profession made decisions to just dismiss it. So it completely went away for probably about 15, 20 years because, there's too many false positives. There's too many this. It's not quite replacing mammography. We have what we need. We don't need you, that kind of thing.
Ah!
Yeah.
I
And
beg
then,
to differ.
right. And then we had some research being done looking at these idea of false positives. And this is one of the most exciting things for me being involved in holistic healthcare is that the idea of a false positive is that the test says there's a problem when there is none. So for a cancer test, this could be very scary, right? The test says you've got cancer, but there is none. Well, with thermography, it's not really specific to cancer. It's specific to activity. And we have to look at what that activity means in the broader scope of body function. And some of these long-term studies that I talked about, there was one that followed 1,500 women over a 12-year period of time. And they found that 40% of the women with these false positives developed breast cancer within 12 years. 40%. And
That's
most
a
of them
large
within
number.
5 years. Yeah. So it raises the question, well, if we know that the patient is higher risk, couldn't that change how they're screened, how they're managed to make sure detection occurs earlier?
Hmm.
And then from the holistic standpoint, do we have a window now to enable prevention and risk reduction? And now a biomarker, something to measure to see if those strategies are improving the situation,
Mm.
right?
Okay, out of curiosity, because what we're told in the Western world, in Western medicine, is start getting regular breast screenings
Mhm.
from your doctor by the time you're 40. That particular study that you brought up, where 40% of the false positives ended up with cancer, when did they start their screenings?
That data I don't have, but I would imagine that they're probably between their 40s and their 50s, the 40s and 60s.
Is it worth it to start doing breast health screening at a medical level, not just a self assessment, but at a medical level when you're younger?
Well, I think it is because you're in a situation where it takes time for a cancer to grow. And what we know about cancer is that some of them grow quickly and some of them grow slowly. If we can catch them at the earlier stages, there tends to be less consequences from it. So I am a firm believer in the idea that early detection saves lives.
Hmm.
What I would love to see is the incorporation of something like thermal imaging at even an earlier age, maybe as early as 30. And we've screened women as early as 20, so we can get an idea of what their body's doing. And then if the function looks like it's changing in a way that suggests risk could be present, not only do we activate the medical arena in order to make sure that there's no cancer occurring right now, but especially in these younger women, we
Hmm.
look at holistically what could be done to improve function and potentially give them an off ramp,
Yep.
right? Because the thing is, it's like it's a trajectory. You have a risk factor. That risk factor stays, multiplies, and the trajectory is towards expressing the disease. But if we can take an off ramp because we found the risk factor to begin with, and we had some feedback in order to monitor whether the changes we were making were effective, we can now effectively go a different direction and potentially prevent cancer from occurring in the first place.
Ah! Okay.
Right.
So,
So my passion is more since, my background, and, I didn't state this originally, but my background is chiropractic. And I got this I got into this as a function of the general wellness community. And I'm always interested to see what we could do for prevention. What could we do for risk reduction? What could we do to support the body so it's as well as possible? And that should always be what we should be thinking about first and foremost. And then, yes, if there's risk, there's a disease. If there's a disease, of course, we check out the medical profession. Of course, we go that direction. But to ignore this piece, to me, is just missing the obvious.
right. Okay. Here's a statistical question you may or may not know the answer to.
Hmm.
If your family has a history of breast cancer or breast issues,
Hmm.
and you know this, how often are those people starting to get detection sooner?
Well, with a family history of breast cancer, and I'm just going to the best of my memory because I'm not in the medical arena. But to my best of my ability, they will start at 40. If they have a very strong family of history, they may be candidates for what we call enhanced screening, which means instead of a mammogram every year, they may get a mammogram and then an ultrasound scattered in. Or if there's a genetic marker like BRCA gene, they may consider MRI screening, which is very sensitive. It picks up a lot, but it really does have a lot of false positives in that situation. So they're very, between the cost and the false positives, they're very judicious as to how much they use it. But this is something that we're starting to see in medicine now, where they're actually looking at risk as a way to determine not just who can be screened, but the level of screening.
Mm.
Right. And to
Yeah.
me, incorporating thermal findings as part of that protocol would be ideal.
Well, let's go into the four things that you just mentioned because it's worth pausing here and talking about them.
Sure.
Mammography.
Hmm.
I was 21 when I had my first mammogram. My breast tissue was way too dense. to be able to see anything in. So the next step for them was to send me to ultrasound. Is
Mhm.
ultrasound the next best thing to mammography if you have dense breast tissue?
It really does depend on the situation. So often ultrasound is the next place they go because ultrasound's not affected by breast density. And breast density, when women are younger, they have dense breasts.
Mhm.
And, as they age, the breasts become less dense. But at the same time, it doesn't mean that they're not dense at all. And some women, they just, and especially, a young, vibrant woman in her 40s, and she has dense breast tissue. That's not a bad thing, right? It's not a
It's
bad thing. It
me.
doesn't mean you're bad, you're wrong, your body made a mistake. It just means that your physiology is expressing that way. And it limits certain screening technologies. So what they're finding now with the high incidence of women that have breast cancer that do have dense breasts, they're finding that enhanced screening is appropriate. Like, okay, maybe we'll do a mammogram every so often just to see if the obvious shows up, but we'll add ultrasound in it to make sure that something's not been missed. I think the thing to remember is that each test, it's like taking a different pair of glasses on. Like, oh, I have my mammogram glasses on. Now I'm going to put my ultrasound glasses on and I'll see a whole bunch of different things that I wouldn't see on the mammogram. And same thing with MRI.
Right. It's interesting you mentioned MRI. So I didn't even realize until I started doing my research for this episode that MRI was an option for breast tissue. I've had MRIs on ACL reconstruction issues, things like that, but never did I think, yes, MRI for a breast. Why are there false positives in MRI technology for breast health?
Oh, it's a great question. And I'd say the false positives are a few reasons. Number one, structurally, sometimes we see things that look suspicious. And then when they're biopsied, we find out that they're not. So
Mhm.
understand with all imaging, you're looking at the shape, the size, the density, the color, all these different parameters and saying, does that look suspicious enough to biopsy? That is really the purpose of imaging.
Yep.
Okay. Is that suspicious? Because the only way you know is a biopsy comes back and finds cancer cells. The other reason why MRI has false positives because it's also a functional study. They usually use some sort of radioactive contrast agent that's used, or not radioactive, but some sort of contrast agent that is used in order to delineate areas that are more active. So we see activity in an area that's now an area of concern. But
Mhm.
just because it's active doesn't mean it's abnormal. For example, you mentioned fibroadenoma. Fibroadenoma is more active than normal tissues. It wouldn't be uncommon to see more activity in that area, and it wouldn't be uncommon to see it looking abnormal. It's why it's one of the most common findings when somebody gets a biopsy and it turned it out to be a false positive. It looked and behaved a little enough like a cancer would that
Mhm.
it required the biopsy.
Yes. At 21, that was the whole reason why I was getting the mammogram and then the
Yeah.
ultrasound, and then we were doing ultrasound and biopsy at the same time. And that was actually where I learned that cancer is attracted to the needle. That was an interesting little tidbit. And they were like, "Oh, yep, we can't even get a sample because it wants to run away from the needle." And I was like,
Hmm.
"Okay, cool. We're
Yeah.
we're good now, but we've now have to monitor this all the time." Which is
Right.
where I ended up going to thermography because mammogram didn't do it for me. My breast tissue was too dense. Getting an ultrasound wasn't the first aha thing that doctors would go to, at least the doctors that I see, and thermography was the thing to go to.
Hmm.
And I find it fascinating that in with thermography and the care that I'm getting with my doctor, my imaging year over year has gotten better and better and better.
That's right.
That's what we want,
That's what we
right?
want.
So, what are some of the images that we would see in a thermography scan that tell us you need to pay attention to this?
Mhm. Well, the first thing to realize is that, you're looking at heat and you're looking at heat patterns. So cancer grows faster than its surrounding tissue. It's more metabolically active, so it tends to produce heat. So I'm looking for asymmetries in heat that's in one area that's not in another area. If somebody has a lump or a clinical finding or something like that, and there's heat in that area, it's more suspicious. Again, it's not a diagnosis of cancer because there are other things that could cause it, but it raises a level of concern. The other piece that I think the thermography is really good at is the idea of looking at vascular structures, blood vessels, because blood vessels have their own heat signature. And on these images, they look actually like blood vessels. You can track them and it's amazing. You think you're looking at anatomy.
Yep.
But based upon how that blood vessel is shaped and how hot it is, we can make inferences to what's going on. There's things that cancer does to the blood supply called neoangiogenesis that completely disrupts the normal distribution of blood vessels. And if we see something that looks similar to that, again, it's another indication, hey, we've got an area here that needs to be investigated.
From the thermography, what's the next step that most doctors would take?
Well, the next step is usually going to be somewhere between either mammography, ultrasound, or MRI, depending on their situation and what they've had done. So, you mentioned dense breast tissue, and especially a younger woman, you were in your 20s. If I saw something on thermography in your 20s, probably the next step is going to be ultrasound. I mean, maybe there's a physician out there that would want to do a mammogram at that age. But more than likely with the density, it's going to end up being ultrasound. I think with the thermography too, because we look at women over time, we can see if these thermal patterns are increasing or decreasing. So, whereas, somebody may come in, they have something unusual, we check them out, they go to their doctor, their other tests are fine. Normally that's where the process stops. But for us, we continue to monitor that activity and see if it changes. Because if it continues to get worse and worse and worse, this could be a signal something was missed on the other tests and we need to be vigilant.
I love that.
Yeah.
How do we find someone who does mammography? How do we find someone who does thermography? Because those are always where our doctors are sending us.
Right.
I feel like the mammography, it's pretty simple. Everybody knows. But
yeah,
when it
your
comes to
doctor's
thermography, how do we find someone to do that for us if our doctors aren't already going, oh, go get a mammogram?
Right. So, with the mammogram part and with those kind of tests, the radiology tests, just go to your doctor. The doctor is going to know exactly where to send you. If your GP doesn't order the test themselves, they'll send you to the appropriate specialist that will know exactly what to order and exactly the sequence. But since thermal imaging isn't part of their algorithms, that's something that you're going to have to look for on your own. Now, I'd say the best place to look for it is through two associations that I'm a part of both. One is the International Academy of Clinical Thermology, and I can give you the website addresses so you can put them in show notes and things like that.
Absolutely.
And the second is the American Academy of Thermology. And both of these associations that belong to them because the guidelines for imaging are very clear and very accurate. Because we're dealing with temperature measurement, we have to be careful. Like if you went ahead and just ran a marathon and then came in and got imaged, your body's pouring off heat. That is not a good time to do a breast thermogram, right? If there's an air conditioner blowing on one part of your body, causing half of your body to be cold, that is not a good environment to do a thermogram. So both of these associations have really delineated, here's what the laboratory should be, here's the conditions, here's the optimal situation so that you have accurate findings. And everybody that's been trained by those associations understands that and incorporates that into the delivery of service.
So I should be going into a room where no air is blowing on me. Temperature is fairly well controlled. Is there a certain temperature range that we want to be in?
Yeah, the standard is between 18 and 23 degrees Celsius. So let me do the conversion into Fahrenheit, somewhere between 66 and 72.
Yep.
So we keep it on the cooler side because that actually allows any heat that's pouring off the body to dissipate. And then we can see a little bit more of what the activity looks like underneath.
Which, I mean, our breasts are right next to our armpits.
Right.
And our armpits are a heat source. So are we standing there like a scarecrow, waiting for the heat to dissipate off from our armpits before we start the imaging?
Well, there's what's called an acclimation process where you're getting used to the room temperature. So remember, you're warm, you're in clothing, which insulates you. And then you walk into a room that's colder. If you just take off your clothing and get imaged, we're going to watch your body cool down. And we've actually done that. I do that in my training course for thermographers. I say, just go ahead, and you don't have to be breast. It could be anything. Just take a back that's been in clothes, and then pull off the shirt, and then just measure the back and watch it. And you watch it cooling. So we need enough time to do that. Now, you brought up a good point about the armpits. They're armpits, so they trap heat. It's also very superficial to the blood supply, so it's an area where we release heat mostly. So what we usually do is have them either have their arms on armrests for about 10 minutes, or on their hips like this. And then for the last 5 minutes, we have them put their arms overhead.
Nice.
And this lets it cool off so we can get a better idea on what's happening in those regions.
Okay. I love that. And the imaging, it's just a regular camera that has the ability to see heat.
Right.
Nothing
Right.
special. It's not like your breast is going to get smashed in a mammogram.
Yeah. No, there's no compression. There's no radiation. If you wanted to, you could stand in front of that camera for 24 hours a day for weeks and months and years. And there would be no side effect other than you wasted your life standing in front of a camera for no reason. Right. But,
Yes.
but yeah, there's no side effects. And, what a regular camera does is it captures light, visible light, and it's part of a spectrum called the electromagnetic spectrum. And visible light's like right in the middle of it. So those wavelengths are what's captured by a camera. Now, there's just to the side of it is what's called the infrared portion of that spectrum. And our body actually takes heat and converts it into infrared energy. And these cameras that we're using they're calibrated to measure in that range. That's what it's capturing. So there's nothing given to the patient. There's nothing delivered to them. It's just reading what's coming off of them naturally.
Beautiful. It makes so much sense to have that just be a part of your regular process. Go stand in front of the camera, get your breast health checked through thermography. It's so simple.
Yeah.
And not stressful, and actually kind of entertaining.
Well, and the thing is for me is that what I really attracted me to looking at thermography for breast imaging was I watch women, and I live in the San Francisco Bay Area, and so many women get breast cancer here, and you watch them all walk around with this victim consciousness. It's going to get me. I hope I don't have it. And I appreciate the fear that's there because a lot of women get it. And, it could be anything from, a simple thing to something that's life-threatening. But when we're starting to look at thermography and we're looking at the idea of identifying, what we call biomarkers, measurable factors that can suggest risk, and then we look at the idea that you can take action and lower risk, all of a sudden I see women move from that victim mentality to more of empowered. Like, I might be able to change this. It's like, yeah. Yes. So, you knew that eating right was good, but how about we eat right and look at what it did to the patterns on the image? We knew that exercise was good. Let's see what it does to the patterns in the image. I've seen women change their image just by eliminating white flour, white sugar, and alcohol for a period of time. Like, it was that simple. And their biomarkers changed. So when we talk about biomarkers, think about like high blood pressure. High blood pressure, I know it's a diagnosed condition, but really it's a biomarker for heart disease, right? If you just had high blood pressure, it wouldn't matter. What matters is that it causes arterial wall thickening, which can cause strokes and heart attacks. That's the problem. So we treat the biomarker, right? We treat the condition of high blood pressure, and we treat that biomarker as a way to prevent the bad stuff. So now with thermography, you're looking at unusual heat patterns as a biomarker of risk for breast disease. If we can use a little fancy footwork and track down why that physiology has been altered and change risk factors and change the image, we've improved the biomarker and effectively lowered risk for breast cancer.
Prevention is key.
Yeah.
And the more doctors that go in that direction, instead of responding and having to do the heavy lifting of removing cancer or doing some sort of cancer treatment instead of working from prevention,
Yeah.
it would change things.
Yeah. And there's a medical doctor right now, Peter Attia. He just had a 60-minute interview. It was amazing.
Yes, it
And
was.
what's great about Peter was he was he was an ER, he was a surgeon dealing with chronic disease, and he just got tired of how much chronic disease was present. And he started looking at biomarkers and ways of prevention. And his whole approach right now is educational. How do we get people to change their body's functions so that they are given an off ramp from the path to chronic disease? Right? Somebody has diabetes. Their father had diabetes. Okay, it's genetic, right? There's not a lot I can do about it. Well, no, that's not true. There's a lot of lifestyle factors that give you an off ramp. And if we can incorporate that methodology, that approach into breast care, and we're just at the surface. I mean, we don't know exactly what's going to be that off ramp, but we have some pretty good ideas. But if we continue to put focus on that and explore it, like we did do with heart disease, like we did do with diabetes, we can now start to get the feedback with the thermal imaging to learn more about what works, what doesn't work, and what's the most effective way to lower risk.
That right there. Yes, Health 2.0, I think that's what Peter Attia is
Yeah.
calling it now, and I love
Yeah. Healthcare medicine 3.0. I love it.
3.0. That's where we're at.
Yeah.
Yes.
And from
Um,
a consciousness standpoint, it's changing victim consciousness into empowerment consciousness. And I think you'll agree, being alive in 2025, we need more empowerment consciousness. There's enough stuff out there to be victims of. And it's time that we took some control back and said, what can I do to give myself the best shot, to improve my health, to have the greatest level of vitality, function, and expression that I can have with the time I've got here.
Absolutely. Dr. Kane, if there is one thing that you could tell women about breast health, what would it be?
What I would say is don't be afraid of information. Get checked, make decisions. Everything is a data point that you could potentially act on. And the more you move into action around your health, whether it's breast health or anything else, the better you're going to feel about yourself, and the better your chances are to avoid the pitfalls of many of these chronic conditions that are out there that become much more debilitating as we get older.
Thank you. Dr. Kane, it has been an honor. I'm going to have you back because we are going to do a little show and tell on the next one.
Ooh,
I
fun.
would love to see some images and
Yeah.
talk about the different scenarios that come up for women and how it presents in thermography and what women can do to help themselves from that point. So thank you.
You're very welcome. Thank you too.